You guys ready? Perfect. So nice to meet you guys. Thanks for joining. My name is Dr. Alexandra Abbott. I'm one of the primary care sports medicine doctors with Stanford Children's. So that means before I was a sports medicine doctor, I was a pediatrician, and I'm excited to present this talk to Cal North and soccer-minded people because before I was a pediatrician, I was a soccer player too. I'm joined by Ted Sueyoshi, who's one of our athletic trainers at Stanford. I'll let Ted introduce himself.
Hello, everyone. My name is Ted Sueyoshi. I am one of the athletic trainers that work at the sports medicine program at Stanford Children's, and I as well participated in other sports, including soccer growing up, and I was always injured, and I wanted to help other people in the same boat. So that's why I got into sports medicine. Thank you, Dr. Abbott.
Yeah, thanks for joining us. So we'll be presenting on ankle injuries today, sharing our knowledge from an athletic training standpoint and from a sports medicine standpoint, but specifically with the nuances related to youth soccer players. So we'll start with the stats. A large study of emergency room cases that included over 1.5 million soccer-related injuries dissected out that about 18% of them were ankle injuries. So that means about 1 in 5 soccer injuries that need a doctor right now are of the ankle. We're also publishing some more data from a large group of over 60,000 pediatric patients next year, which shows that about 1 in 4 of kids' musculoskeletal injuries and about 1 in 5 of their broken bones are related to the foot and ankle. As kids get older, they have a higher risk for fibula fracture, which is commonly sustained from rolling the ankle or inversion in sport. A little more than 1 in 10 of fractures in teenagers are of that fibula bone. So overall, kids hurt their ankles and they break their ankles pretty frequently, and it results in a lot of young soccer players having to go to the emergency room. More stats. A study last year compiled the data from over 100 other studies of soccer players and found that the ankle is the most common injury site for them. Concordant with our study, they found that the risk for ankle injuries is higher in older children, like teenagers. Many studies have demonstrated about a 25% higher risk for ankle injuries in female athletes than male athletes, but the prevalence for all soccer players to have an ankle injury is high, up to 50% in some studies. Many studies use the metric of hours of exposure in sport to quantify how frequently injury occurs, but exposure hours can be hard to translate to real-world examples. So if we crunch those numbers that we have from our data, we can convert this to metrics that apply to our kids. So for boys on average, we see 6 ankle injuries for every 1,000 soccer hours. This converts to an ankle injury every 3 to 4 months if a boy is playing soccer for 10 hours weekly, which would be a reasonable amount on average. So if you think about a year-round soccer player, every 3 to 4 months is an ankle injury every season. This study from 2022 looked at just high school athletes and similarly used 10,000 athletic events as the sort of complicated denominator to help quantify ankle injury risk. To crunch this again into real world numbers is difficult because hopefully your kid is not playing 10,000 athletic events in high school. But if you take, let's say, just 2 teams of athletes from a high school who are playing 5 times a week each, you can expect the group to have about 3 ankle injuries per year on average. So imagine how many ankle injuries you'd have in a whole high school of teams, in all the high schools in the United States, et cetera, especially if these athletes are also playing more frequently, like when they're in season. The risk is also doubled for soccer players. So a high school athletic trainer, if Ted was working at a high school, or even if you're just an athletic trainer that has management for 1 or 2 soccer teams, you better know how to manage ankle injuries. So ankle injuries are common. We know that female athletes, teenagers, and soccer players are at the highest risk based on that data from previous studies. But how do these ankle injuries happen on a single individual scale? So we'll step back and talk about some of the jargon that the doctors are using. An acute injury or a sudden injury usually happens when someone rolls or inverts their ankle. So inversion injuries can be just without contact, or they can be made more severe if it happens with a slide tackle, someone stepping on your ankle, or some other kind of collision. To contrast, a chronic ankle injury describes when you have ankle pain that didn't start from one discrete mechanism. The patient usually can't describe a specific play that happened. They just kind of had ankle pain that came on more gradually, or last season they started having a bad ankle. We found that ankle injuries are more likely to occur when someone has poor balance, which we've learned can be studied accurately with the STAR balance test demonstrated in the top right. We also know that ankle injuries are more likely to occur when someone has a history of an ankle injury and when someone has relative weakness in the muscles in the posterior chain. So these are the muscles in the back of the leg. When someone has a history of ankle injury, the hypothesis is that the ligaments that got stretched are less tight because of that trauma, modeled by the rubber band that's being stretched repeatedly, and you can imagine would have less elasticity than a rubber band that had never been stretched. So in this case, the analogy is the rubber band are the ligaments that got overstretched in this inversion injury. Someone with a history of ankle injury also has demonstrated that they have some kind of predisposition potentially. So they may need their suboptimal biomechanics corrected before that risk for recurrent injury is decreased. Someone who rolls their ankle might not get injured, but if you do roll your ankle and then you are showing signs of a true injury, this is what you might see. So pain, especially immediately afterwards, swelling, bruising around the area, stiffness or difficulty ranging your ankle, or if you're just not able to put weight on it or having difficulty putting your full weight on it. Someone with a chronic ankle injury might start limiting how well they can train, or it might make them run, walk, or just play differently to avoid that specific ankle pain. Some ankle injuries, when we talk about acute ones, the most common ones are ligament sprains, as we've talked about already, fractures or broken bones. And in kids, we also think about growth plate injuries. As we talked about before, teenagers are particularly susceptible to fractures of the fibula growth plate when they're rolling their ankles. We think that the intersection in the teenage years of high forces from being bigger and faster, but also with still open growth plates during those teenage years, is the reason why they have a higher risk for growth plate injuries and growth plate fractures than younger children who also still have open growth plates. In addition to some of the common ankle sprains of the ligaments that connect the foot bones to the ankle bones, sometimes you might hear about a high ankle sprain and not sure what that means. This just means that the ligaments that connect the bones in the shin, the tibia and the fibula, so the ligaments between those two bones instead are affected, instead of the ligaments connecting the bones in the leg to the bones in the foot. The high ankle sprain is rare because the mechanism often requires the foot to evert instead of invert, so rolling outward, which is an odd mechanism. And it usually has to happen at the same time that the leg or the shin bones are rotating in the opposite direction. We see this most commonly in football players because of the weird and ugly ankle mechanics that happen when someone tackles you in a random direction while you're running away. Often the football commentators, you'll hear them cringing when they're hearing the doctors are diagnosing their favorite player or your fantasy league player with a high ankle sprain, because the recovery time can be double the typical ankle sprain. So some chronic ankle injuries in children we commonly diagnose in our clinics: Seaver's disease, osteochondritis dissecans, other types of overuse injuries broadly, and ankle impingement. So I'll talk about those. So we'll start with Seaver's disease. Seaver's disease is just a dramatic name for inflammation or stress at the growth plate in the heel, usually from trauma like jumping, running, and then the tight calf muscles forcing the Achilles tendon where it inserts near the growth plate to yank upwards on it. We see severs commonly in gymnasts and dancers, but many young athletes of different sports go through this problem. The pain at the growth plate will go away once the growth plate closes during puberty, because it's no longer that weak point in the chain. But kids don't have to be miserable while they're waiting for their growth plates to close and while they're waiting for puberty. You can use heel cups, which kind of act like they fit like orthotics or other types of shoe inserts, but they offload trauma specifically to the heel when you're landing in your heel strike for running. You can also use ice and NSAIDs, which are definitely underrated for treatment of growth plate injuries and growth plate inflammation. They can really reduce that inflammation and pain at the end of the day. And then stretching the calves so that the Achilles is not pulling so hard on the growth plate is also really important. Okay, so the next type of chronic injury we have is the OCD lesion, osteochondritis dissecans. This is not the OCD that you typically think of, but we're essentially describing an abnormal separation of the bone and the cartilage that's inside the joint. This can happen in an ankle joint, and we see this on the x-ray between the first bone in the foot on the bottom, that's the talus, and then the tibia, one of the shin bones in the top. We usually see the OCD lesions in patients aged 10 to 20 years old, and we use x-rays and MRIs to grade them. So depending on how much inflammation and how much separation there is between the host bone or the bone where the fragment came from and the fragment itself, some patients just need rest for the low grade ones. But if there's a ton of inflammation and there's edema separating the fragment from the bone and it's not likely to reunite with rest alone, these patients often need surgery. Chronic ankle pain can also be from just overuse injuries. So we think about strains of the muscles and the tendons. These we see when someone has progressed with too much volume or too fast in how they're progressing their exercise volume. So we think about weekend warrior types or athletes who are sedentary in the summer and then pick up the boot camp phenomena in the fall, picking up muscle and tendon strains because these structures just haven't had time to adapt to the new load. We also see this when someone just doesn't have enough rest and recovery in between sessions, especially if they don't have any days off during their weekly training periods. The treatment for strain is rest from painful activities to allow the structures to heal so that you can start reloading and traumatizing the muscles and tendons. The last specific ankle injury or diagnosis that we'll talk about is ankle impingement. We see ankle impingement more commonly in older athletes because repeated trauma to the ankle joint results in scar tissue of the soft tissues, and then osteophytes, also called bone spurs, of the bone developing from that trauma. The soft tissues and the bones essentially think they're being helpful by putting something hard in the way of the trauma that's coming to it, kind of like a shield, but it's actually more acting like a monkey wrench that you put in a hinge joint. And when you try to range the ankle, the structures are getting pinched. So it can cause pain in the pinch point, and it can also cause a mechanical block that prevents range of motion of the ankle. On the bottom left, you can see an x-ray on the left for figure A and then an MRI for figure B showing osteophytes on the x-ray, and then on the MRI, the inflammation with the white signaling and scar tissue of the soft tissues. This is imaging from a pro soccer player who has both anterior and posterior or front and back ankle impingement. So often differentiating the different specific ankle injuries that we talked about, we can sort that out in a clinic by understanding the mechanism of injury by talking to the athlete, and with a physical exam, sort of determining how their ankle stability is, what their ligament laxity looks like, and where they're tender for the most part. But providers also use the Ottawa ankle rules with their physical exam to try and correlate how likely it is that someone doesn't have a sprain, but they actually have a fracture or a broken bone. And then that helps us to decide how useful an X-ray might be. Most ankle injuries are commonly treated with ice, anti-inflammatories, rest, and compression for the swelling. If someone can't walk or if they have a broken bone diagnosed, then we'll use a cast or a cam boot and maybe even crutches to help immobilize the joint and optimize the healing of the bones and the ligaments. Once we've resolved the pain from a sprain, we often will use the lace-up ankle brace that you can see on the bottom right for up to 2 months after the pain is resolved because of that high risk for a repeat sprain, with the loose ligaments. Some people opt to use these ankle braces indefinitely just because it provides more support and because we know that once you've sprained your ankle once, you're at higher risk for spraining it again. So the ankle brace helps to prevent from that inversion mechanism. Of note, the ankle braces, the lace-up type specifically, also called an ASO brace, has been studied against ankle taping and the high top style, like basketball type shoes that have been recently converted into the stylish football cleats and soccer cleats. The lace-up ankle brace does superiorly to both of those other types of potential preventive measures for ankle injuries. Ankle injuries can also be prevented with neuromuscular training, ankle strengthening, and improving the ankle proprioception. We call this prehab if you don't have an injury yet, but you want to make sure that your biomechanics are supporting you and helping you prevent injury. In kids with open growth plates, we think about protecting them from overuse injuries more conservatively. I could offer a completely separate talk on this topic. I talk about sports specialization pretty frequently, and I have some research in that field. But for sports specialization, we have some rules of thumb that help keep athletes from getting hurt as frequently. We've learned from our studies of youth athletes that they're at a greater risk for injury when they don't have at least 1 day of weekly rest, when they don't have an off season of 3 to 4 months, off season meaning they're focused more on rest or on another sport, and when they exceed the number of their age for weekly hours in sport. So to give an example, a 9-year-old playing soccer 12 hours a week is exceeding their number of hours per week for their age. They're playing on all the travel teams, so they're year-round with no rest day because he wants to work on his penalties on Sundays with his dad. He's breaking all the rules, and he will be seeing me in my clinic. And then finally, I included the ASO lace-up ankle brace again as a preventive option to remind you about that. And then a reminder that your sports medicine providers are the ones who can help to determine if X-ray vision is needed to diagnose a fracture instead of a sprain. And then lastly, this study was a really good one, I thought, to include. It showed that AstroTurf seems to set up athletes for more injuries, especially in the lower extremity. I was a goalkeeper, so I preferred AstroTurf, but none of my friends did because they all felt like they were getting injured. And so it was nice to have this study to validate what my teammates were telling me. As a goalkeeper, I liked AstroTurf because the ball would never hit an uneven patch of grass and bounce in an odd direction. But our thought about why AstroTurf or why artificial turf seems to set people up more for lower extremity injuries is that, especially for the ankle, when you're landing your foot and your foot strikes the ground, we're finding that athletes seem to place more of the load on the outside part of their foot, the lateral aspect we call it, where the pinky toe is, instead of more evenly between the big toe and the pinky toe. So if you can imagine, landing on the outside of your foot more sets you up for that inversion and rolling your ankle. We included our references in case you'd like to read the primary literature yourself, or if you want to read more about ankle injuries. And we're excited to help you out in any part of the Bay. I included the list of my colleagues in primary care sports medicine. So these are all primary care physicians who became sports medicine doctors and then joined Stanford Children. So our map on the left shows where Stanford Children's orthopedics locations are. And then we have primary care sports medicine doctors. We describe ourselves often that we're the sports medicine doctors who are trying to keep you out of an operating room, but we work closely with the orthopedic surgeons at all of these locations. We have primary care sports medicine doctors at every location except for San Francisco right now. And then I included this picture on the right. I can't tell you how old it is, but it kind of gives you insight about where my passion for sports medicine started. So it's nice to come full circle and talk to coaches who could have been my coaches back in the day, things like that, trying to help us on the field, and then bringing the scientific knowledge and being a sports nerd and teaching everybody where my passion came from. So very excited to chat with you guys and answer any of your questions. And then if Ted has anything to add to, we'll kind of collaborate on the Q&A. Let's see. Yeah, we have some questions already. Okay, let's see. Yeah, okay, this first question is great. How can a parent know when a teen athlete is ready to return to soccer after a lateral ankle sprain? So we talked about the period of time after an ankle sprain. So if someone comes to me with an ankle sprain and they are able to walk, but they just have pain over the ligaments that were sprained, I will let them have the choice to wear a cam boot or not. I recommend cam boots for people who need immobilization, because especially if they can't walk on it. But you can also use a cam boot to try and speed up the recovery time of that ligament. The sort of mechanism of that is that when the ankle is still ranging and you still have sort of stress going on at the ankle joint, you're still kind of stretching out that ligament and putting trauma where it's trying to heal its micro tears. So the cam boot, even if you are weight bearing, might be helpful for speeding things up. And then to answer your question, when am I ready to return to soccer? So I always describe to my patients, you have to walk before you run, and you have to be able to walk before you walk. So the athletes who are not weight bearing still because they have too much pain, they're not ready to go back. The athletes who are limping or who are kind of walking differently or running differently are not ready to go back. I need you to feel like your right ankle feels the same as your left before you can kind of re-challenge things. And then we talked a lot about the lace-up ankle brace. So that can really be helpful in that first 2 months period after an ankle sprain to help not just give the athlete confidence in it, but to help prevent that risk for re-injury.
Can I add something to it, Dr. Abbott?
Of course, yes.
So ankle injury, I think, is one of the most common injuries across all sports. And I think at the same time, ankle injury might be the most ignored, undertreated injury of all. And then, ideally, ankle injury should be also treated with physical therapy that could also help recovery process, also preventing further injuries as well. Any thoughts on that, Dr. Abbott?
I would tend to agree. I feel like many of our athletes are coming to us and they're trying to be strategic with their sort of soccer seasons and trying to get through injuries and things like this. I think it's really important that we're not trying to make injuries worse, and we're cognizant that pain is not just something our body is doing to get in the way of us scoring goals in training, but it's our body telling us that there's a construction site that's trying to heal and we're not letting it. So pain is your body's signal that there's something healing going on, and we're not giving it the rest and recovery that it needs. Okay, this other question is an interesting one. Is the soccer shoe choice important to prevent ankle injuries? So I would say this sort of dovetails nicely with our discussion about the high top style shoes, and that I'm seeing more I don't know if it's more related for youth athletes, that if I had to poll them, if I asked them, why are you wearing the high top shoes for football, not just basketball? But also I've seen this for soccer as well. If the athletes are just liking them because it's the style of the Air Force Ones and the fashion, or if they actually feel like this is helping them prevent ankle sprains. But that lace-up brace is the only one that has stood the test in terms of superiority of actually preventing ankle sprains, especially for people who've had them in the past. We don't have great studies on specific types of shoes. I think physicians and researchers are averse to putting brands up against each other. So we don't have like Nike versus Adidas studies or things like that. And if we did, I would be skeptical about who is funding them. But I would say it's important that your shoe's fitting well. Some patients overpronate, meaning they roll their foot inwards and sort of lose their arch when they're running. So sometimes adding an insole for athletes who seem to have flat feet can be helpful for making sure that that ankle to foot junction is more stable and not wobbling back and forth when they're running. But in terms of Nike, Adidas, Puma, I think whatever the athlete is feeling comfortable with is a good idea. And then someone asked, Ted, you might want to talk about this one. What exercises do you recommend to strengthen the ankle area?
So to strengthen the ankle area, most common exercises that are used to do that was the four-way ankle exercise with the exercise band that's wrapped around the ankle, and then the athletes moving their ankle against the resistance, side to side, up and down. Also can be achieved by doing some heel raises on the floor, and balance exercise on the balance pad is another common exercise, one to strengthening ankle area, muscle tendons, and also to improve balance. And also research has shown that hip exercise may prevent a ankle injury along with knee injuries as well. So laying on the side and lifting the leg up and down to strengthen the hip exercise, also core exercises, and then any other balance exercise to improve proprioception and then postural balance are shown to improve a biomechanical aspect of the human body and also prevent injuries. But so in terms of preventing and then recovering from injury, we just don't focus on ankle only. We also focus on other areas as well that can contribute to an ankle injury.
Yeah, I agree with everything that Ted is saying. I'm really glad we have an athletic trainer on our webinar. Athletic trainers and physical therapists are the type of people that we send our athletes to for these types of exercises. So I will write a prescription that says something like what we described earlier in the discussion, posterior chain strengthening, ankle proprioception, and ankle strengthening. But I'm not standing on a medicine ball in clinic with the patients. Ted is the one who's in the physical therapist's office or in the training room with the athletes, teaching them how to do these exercises and watching their form, making sure that they're doing them appropriately, but then giving them home exercise plans so that they know how to do them at home and lifelong. I often describe to patients that going to physical therapy or going to one session with a trainer or a physical therapist is sort of like going to the dentist. But then if you never brushed your teeth and you went to the dentist twice a year, you would still have terrible teeth. So it's important to make these exercises, especially if you're set up with biomechanics for an ankle injury, make them part of your warm-up, make them part of your cool down, do them while you're brushing your teeth, to combine the metaphors. And then if they're part of your routine, then you know that you have bulletproof ankles. And like Ted was saying, sideline leg raises, single leg squats, these kind of movements that we don't commonly see in warm-ups. Those can all be really great for the repertoire to help prevent injuries. Someone asked, is rice the best method to use when an ankle injury happens? So rice is a great is great for all the different types of injuries that we talked about. So we also describe it as PRICE that came out recently: protect, rest, ice, compression, and elevation. All of them are modalities to help prevent worsening injury or exacerbation of your current injury. And then to try and reduce swelling and inflammation immediately after the ankle injury occurs. Usually these are helpful in the first week or so after the injury, and then after a week or two, if the pain is still there and you haven't seen a doctor, it's probably a good idea to see one to make sure that you're not just ricing a broken bone and putting weight on it or not properly immobilizing it. So rice is great for most of the soft tissue injuries and sprains, but if it's not working or if it's taking more than a week to sort of get back to normal, then I'd consider seeing your sports medicine doctor. Do you recommend taping always or wearing an ASO always once a team player has sprained an ankle, even after the 2 months using an ASO or lace-up brace? So I would say, like I said, I'm commonly recommending the lace-up brace for that 2-month period because that's your highest risk for re-injury as you get back to sport for that inversion mechanism, especially. Taping head-to-head against lace-up brace is inferior when comparing the risk for ankle injury and recurrent ankle injuries in our studies. But if you're asking, should we always be wearing a lace-up brace? I will say there's pros and cons. One, the pro is if you're wearing a lace-up brace, your risk for ankle injury goes down significantly. But the risk for something I describe as kinesiophobia goes up. So kinesio means movement and phobia means fear. If a patient or one of the young athletes is wearing a lace-up ankle brace all the time and they feel like if I don't have my ankle brace on, I'm going to sprain my ankle, then if they forget to put it in their backpack, they move differently when they have to train and things go wrong when they don't have it. So I think the better sort of long-term solution is to use the lace-up brace while you're working with someone like Ted on your ankle proprioception and strengthening, and trying to work on making your ankles bulletproof from within, making those muscles in the ankle stronger so that the muscles are doing the work of the lace-up brace. And then once you have the confidence that you can stand on a medicine ball and catch something and your ankle doesn't move, that you don't really need the lace-up brace. They're good questions. Okay, so someone says, another question about lace-up braces. Can a lace-up brace be used even without an ankle injury as a preventive measure? I have an 8-year-old starting a competitive team. Again, like I said, lace-up braces, if you're wearing it, your risk for ankle injury goes down significantly. The preventive measure of prehab, like we talked about, so you haven't had an injury yet, but you feel like you have loose ankles or your ankles could be stronger, doing that prehab as a preventive measure is also great. But there's no problem with lace-up braces. They can fit inside your cleats and they're pretty comfortable, so it's okay to use them all the time. Someone said, thanks, PT sounds great for an ankle sprain, but all of the PT providers are booked for the next month. So during COVID, a lot of PTs closed because no one was playing competitive sports. And then after post-pandemic occurred, everybody's playing sports and they're going from 0 to 100 and getting injured. So we're back on the pendulum swing of creating more PTs because the demand is there. I hear a lot that patients are trying to get into physical therapy and they're having trouble. I often will give patients a home exercise plan when they come to see me. So seeing your sports medicine doctor can help you with that too. And then I also have a list of physical therapy providers, and sometimes your doctor can advocate for you getting in faster if you need it. We talked about what are good exercises for strengthening the ankle to help prevent potential ankle injuries. We answered that question. You guys have a lot of similar questions. This is great that we're able to answer questions that everybody has. Someone asked, do Epsom salt rubs or Epsom salt baths help with ankle sprains and ibuprofen? So our evidence for ibuprofen is ibuprofen is a non-steroidal anti-inflammatory or an NSAID type medication. NSAIDs are also, they're all in the same class for Advil, Motrin. So you might hear those brand names used interchangeably. Those help a lot with pain, but they also help with swelling. Most children, as long as you haven't been told by another doctor that you can't take NSAIDs for some reason, usually related to the stomach or kidneys, they can take anti-inflammatories for pain and for swelling. And they, I would say, are definitely underrated and underdosed commonly by patients who just take one little one and hope it works. It's good to know your kid's dose, which your pediatrician should be able to help you with, or the back of the bottle. And then in that first week when you're in your rice zone, trying to help with the acute inflammation, being on a schedule 3 times a day of ibuprofen can really help bring down the inflammation and speed up the recovery. I'm not aware of Epsom salt data. I haven't come across data that suggests that Epsom salts are helpful for inflammation. I know that warm baths and heat in general can help relax muscles, but often heat we think of as increasing inflammation of an area because it's bringing more blood flow and more swelling potentially. So I usually favor ice over warmth. Unless someone has a really bad muscle spasm or something, which is uncommon for the ankle joint. Someone asked, does ibuprofen hinder healing since inflammation is actually part of the healing process? That's a great question. So when I think about overuse injuries, like let's talk about the tendons as an example. Tendinitis, itis is just a medical word that the suffix that we add to the location of the body to say there's some kind of inflammation or stress here. So let's say you have tendinitis, the tendon is stressed out from overuse and we've got inflammation in that zone. That inflammation is bringing new cells to try and help heal the micro tears that you have. But if you're resting because you know about the injury because of pain, you don't necessarily need more swelling and more fluid in that area. It's just causing pain and discomfort. So we treat the symptoms, but the goal is not that we're masking the symptoms and blocking inflammation so that we can keep playing. We're trying to help keep the athlete comfortable while they're resting so that the tendinitis can resolve and they're not miserable in the meantime. When tendinitis progresses, because we keep spamming that same tendon through sport, we start to see development of scar tissue, which is that maladaptive aspect of the inflammation. And that scar tissue starts replacing good tendon for non-functional tissue that just is in the way. So the ibuprofen can help prevent that scar tissue, help reduce the inflammation and pain. But then after about a week or so, you're past your sort of acute inflammatory phase. And anti-inflammatories are not likely to be changing that mechanism of tendinitis to tendinosis, or other, when we apply to muscles or bones or things like that, those other types of inflammations. This one says, does my child need to be fitted for a lace-up brace or can I buy it online? I would say most people get by buying them online. If you know the shoe size, you can often estimate the size for the lace-up brace, but in order to minimize returns because something feels too tight or too loose, you will know if it's too tight or too loose. Then just getting it in person or going to your sports medicine doctor or urgent care or pediatrician so that they can fit it for you. But it's not fine-tuned the way like a custom orthotics for the shoe would be or something like that. It's a little bit more, not one size fits all, but small, medium, large is you'll get by with certain sizes. Is the lace-up brace available for most children sizes? Yes, we give lace-up ankle braces to really young kids. The other sort of Google term, if you're in Amazon trying to find something, the ASO brace is the other name that we gave for it. Can one play soccer wearing a lace-up brace? My kid is convinced it's too restrictive. Yes, you can play soccer wearing a lace-up brace. Football players play with it too. If it feels too tight, it might be too tight. And if it feels like it's not fitting appropriately underneath shin guards, instead of getting the shin guards that wrap under the ankle, just getting the slip-in ones and then wearing the ankle brace underneath. Even if you're just doing that for the affected leg, that can be fine. But we have players wearing more padding than soccer players wearing lace-up braces, and they do fine. Some kids just don't want to add more things though. What's the youngest age of a player that you've seen have their ankle injured? Should I be concerned if a 9-year-old has an ankle injury? So no, I would say the earliest in terms of non-fracture ankle injuries that I see is young school age, like kindergarten and those kind of ages. That's sort of when they start having enough body mass, body weight to roll the ankle in a meaningful way. The 2-year-olds and 3-year-olds, when they come for ankle injuries, it's usually because they broke their bones or something like that. And then around the 6 to 9-year-old age is when I start to see patients complaining to me of the ankle pain from severs. That was what we talked about earlier, that growth plate in the back of the heel. But 9-year-old is sort of prime age for that as well. But I'd be surprised to see a 9-year-old who's inverted their ankle, especially with the high volumes of sports that kids are engaged in right now. Can you explain grading in ankle injuries and how it affects recovery? That's a great question. So we grade ankle injuries kind of academically. It's a little bit of a academic, nerdy endeavor to grade your ankle injury because it doesn't change your management. So the grade just determines whether you just have a small amount of tears in the fibers of the ligament. So again, going back to that rubber band analogy, your grades can define how much percentage of that rubber band has been irritated or torn by the overstretch. Someone with a full tear, they often need surgery if the ligament that's fully torn is not, as we described, redundant with other ligaments. So if there's other ligaments or muscles that can't do the same job of the ligament that's been torn, then you need surgery to connect that rubber band back together. But if you have a partial tear of a ligament or inflammation and overstretching without any tear, then we treat them all the same. We're immobilizing them if they can't walk on them, resting them, trying to help with the inflammation and the pain, and just allowing that structure to heal until they're ready to get back to sport. And then sort of reverse engineering, why did this happen? Here's your lace-up brace to prevent it from happening, especially in the first 2 months. And then consider physical therapy or home exercise programs so that your ankle is bulletproof again for preventing re-injury. We often can't grade the injury super fine-tuned unless we have an MRI. So if I assess pretty dramatic laxity when I'm looking at an ankle joint, I can guess that someone has a complete tear. If there seems to be not a disproportionately low amount of pain when I'm stressing that ligament, it's suggesting that those fibers are not signaling stretch because they're not connected. Or if the laxity is really pronounced and it seems like that ligament's not doing its job in preventing that translation, that movement, that would be when I'm checking an MRI, and then I would confirm that full tear grade. For everything below full tear, getting an MRI is, again, just sort of an academic and nerdy sort of endeavor where you're just trying to see what's going on, but it's not helping to change management. We're going to treat them the same way. So exploring and doing this experiment where I have an athlete sit in an MRI machine so that I can say, oh, yeah, this is grade 2. It's not helpful for the athlete. Is there training we should be doing to help strengthen the ankle during soccer? We answered that one. Oh, this is a great question. Do you have advice for a younger soccer player ages 6 to 9 whose ankles periodically ache but don't have persistent acute pain? So this is a type of question that it's like asking for a friend. There might be someone in my house that has periodic ankle aching but not persistent acute pain. So like I said, 6 to 9 is a prime time age for that Sever's diagnosis where the growth plate is getting irritated. But it would be easier to diagnose this patient. I would say if I knew where the ankle pain specifically is, if there ever was a specific inversion or other mechanism that maybe is a acute injury that just kind of hasn't resolved. But if someone just has, as we would describe, relatively weak ankles where the muscles in the ankles aren't supporting them, they could have overuse or strains of the area around. The x-ray would help me to rule out an old fracture that hasn't been given enough time to rest and heal. It would also help me rule out the OCD lesion, that little bone fragment that sits inside the joints. But I would say that's less likely in someone who has both side ankle pain. It'd be unusual to have OCD lesions in both ankles. But seeing your doctor can be really helpful to help reassure you and help figure out what specifically is going on. My daughter's in soccer and also volleyball player. She's traveling and all weekend in tournaments. Are there any exercises, home remedies, or other therapies we should do to keep the feet and ankles strong? So I would say soccer and volleyball players come to me quite frequently for ankle injuries. The ankle exercises that Ted had talked about before are all great for soccer players and for volleyball players. I would say I love that your child plays 2 different sports because I would describe them as a multi-sport athlete, which helps reduce the risk for injury and helps them have a greater chance at success in terms of longevity of their sport. They're more likely to become an Olympian or a Division I college soccer player or a professional athlete if they diversified when they were young and played multiple different sports. Like I said, I could do a whole separate webinar on that for sport specialization. But then thinking about those rules of thumb, I'll reiterate them again. This mom said that her daughter's playing in all weekend tournaments. So if we have 0 days off during the week from soccer or volleyball, depending on which season you're in, during that week, you're more likely to have to come see me. If she is, I don't know how old she is, but let's say she's 10 and she's exceeding 10 hours a week of either volleyball or soccer. So she can do 6 and 6 of each of them. But if she's doing 10 hours or more a week of soccer or 10 hours or more a week of volleyball, then that means we're exceeding our primary sport, and then you're more likely to see me again. And then if either of those sports, so soccer and volleyball, if they take turns throughout the year, that's great. If there's ever a season where they're overlapping because soccer's year-round or volleyball is year-round, then you're also at more risk for seeing me because you're playing a single sport year-round. Essentially, the hypothesis is that it's similar to adults who don't cross-train. Cross-training is thought to sort of share the love, share the load around the whole body so that you're not putting wear and tear on the same exact muscle groups that you need for those movement patterns. So soccer and volleyball, just to stick with this example, are great in terms of how different they are. So the soccer player, especially if they're not a goalkeeper, is using more of their leg muscles and more lateral forward backwards movements than the lateral movements that you need in volleyball. And then in volleyball, a lot more overhead. So if they were year-round volleyball, I would expect them to come in for shoulder injuries. And if they were year-round soccer, then I would expect them to come for knee and ankle injuries, most likely. If we split it up, then we share the load and allow for some recovery in the other 6 months. And then someone asked, will there be a replay for this? I want to rewatch the ankle exercises piece. I think our coordinator, Amy Brooks, is typing answer to that one, but we'll have this information available after the webinar too. Do grip socks help with preventing ankle sprains? So grip socks, I know I've prescribed or recommended grip socks for people who are doing like Pilates or yoga or things like that. But I haven't seen literature on grip socks for ball sports or sort of like team sport type of things. Ted, have you seen anything about grip socks for soccer players?
No, not that I know of. I haven't seen any.
If I had to guess, if I was going to design a study on grip socks, I would have to guess that they wouldn't change much because everybody's wearing cleats, and the cleats give you traction with the dirt and the grass regardless. The grip socks would just give you more traction between your foot and your shoe. But I would expect that if your shoe fits well, that your foot should not be moving inside your shoe. So I don't think grip socks necessarily have much, but I don't think it's been studied. So something to think about. And I appreciate the feedback about what things people are thinking about, because I'm always interested to know what fads and trends are popping up. Are shin splints related to weak ankles? So shin splints, the medical term for that is medial tibial stress syndrome. That's essentially describing where the tibia or the shin bone doesn't have a stress fracture or bone stress injury, but it's kind of like like you're on your way there. So you're loading the shins in a way that either is too much, too fast, or you're not recovering enough in between the sessions. And sort of similarly to our discussion about muscles and tendons, we do micro tears of the muscles and tendons when we're active, and those micro tears are allowed to become stronger, and we see muscle hypertrophy with the right blend of work and recovery. Bones do something similar. So when you load a bone, let's say you go for a run and you load your tibias or your shin bones repeatedly, it sends signals that there was load occurring. And then your osteocytes, those are your bone cells, come in and add the osteoblasts, put down new osteocytes and create more bone where you need it because of the load. So the shin splints and stress fractures we see when someone is supposed to be loading bone, but they're going for a run instead of recovering, and we're breaking it down again. So that work and recovery cycle gets offset. Are shin splints related to weak ankles? I would say no. Weak ankles, I think more about when I describe that someone has relative ankle weakness, the muscles that are supporting the ankle joint itself just don't have the strength needed to prevent from inversions or overuse of a specific muscle group. And so some of those exercises that we talked about would help strengthen the ankles, but might not help you preventing shin splints or stress fractures in the shin if you're still not with a good progressive increase of your running mileage or your training volume, and if your work rest cycles aren't there. And then a couple questions about topicals. Applying external glucosamine, applying external arnica for the ankle after training, and then Tiger Balm and patches. So I know that there's some products like capsaicin and things that have sort of hot and cold cooling effects on the skin itself. There is evidence that suggests that those are helpful for things like pain, but not related to recovery time of ankle sprain, especially if someone is diagnosed with an ankle sprain, or preventing future injuries or things like that. There's also some question about whether these topicals have a significant placebo effect because of that hot and cold feeling that you feel on the skin, perhaps distracting you from the inflammation underneath. We have studied Voltaren gel, more in adults than children, but Voltaren gel is essentially a topical NSAID or like a topical ibuprofen. And so if your affected structure, like let's say it's one of the ankle muscles or ligaments that's close to the surface of the skin, is superficial enough, then the thought is that the Voltaren gel could permeate the skin enough to actually reduce inflammation without having to take systemic Motrin or ibuprofen and potentially affect your kidneys or stomach negatively. So I know that we promote Voltaren a little bit more than Arnica, but I've heard good things about Arnica from my patients. And then glucosamine is studied in terms of how effective it is. We think about it more for helping to stave off arthritis in older patients. People will take glucosamine chondroitin to try and help preserve cartilage in the joints, but I haven't seen this applied to children. Any passionate thoughts about Tiger Balm, Ted? You're muted, but I'm going to take that as a no.
I'm sorry. No, I do not really have any passionate thoughts, but if someone's in pain, if it helps, I mean, I would say why not, unless it's contraindicated. But another option is to isolate, I guess. But I do not have any thoughts on tropicals. But
okay. So we've almost answered all the questions. I feel really proud to clean out this inbox. You guys had a lot of great questions. We have a few more minutes. I see that one person has asked 2 questions that I didn't answer. I think they might be the same, but or about the same athlete. He says, I have a soccer athlete who has symmetrical pain in both lower legs or in his calves. It seems chronic, not acute. It starts within 10 minutes of playing. Could it be a growth spurt or maybe tendinopathy? And then he asked again, my son has been a soccer athlete for 8 years. He strength trains and has started doing calf raises every day in high repetition when he was younger. He's 16 now and he's having acute chronic pain in his calves. We changed his diet, multivitamins, foam rolling, and ice with anti-inflammatories, but he still has pain. So if I saw you in clinic, I would ask you about how long this sort of acute on chronic, like it sounds like it waxes and wanes, but how long this has been going on, and then what if he's been spamming the calf raises recently or if he fell off on those exercises. So that would tell me if we're looking more at like a strain or like a weakness picture. An x-ray of his ankles would help me to know if it seems like it's related to the ankle joint itself, especially if my exam wasn't elucidating a lot of tenderness in his calves. I would want to know what's going on with the bones underneath. Since it's both ankles, it's less likely to be something like a lesion in the bone or abnormal bony growth. But that would help me to reassure. I'm just checking boxes and making sure that I'm not missing anything. And then if it seems like it's more the calves versus the Achilles, that helps me to change the physical therapy prescription. For strengthening the calves, we do things like calf raises. But when we want to strengthen the tendon, so the Achilles tendon, when we relate it to the calf muscles, we think about something called eccentric movements. So on a calf raise, when you raise up like this, you go up, that's concentric, where you're shortening the muscle and you're working against gravity. When the ankle's up like this, and then I go down slowly, the tendon is loaded like a rope, and that we find strengthens the tendon and helps to more proportionately strengthen the tendon over the muscle when you go slow on the down. So people describe tempo raises and things like that. If I was elucidating on your son's exam, Achilles problem versus calf problem, then I would know which of those types of exercises to do. But like I said, the calves are sitting in front of your tibias, your fibula, your tibia, your fibula, your talus bone in the foot, the ankle joint itself. There's muscles on the sides and ligaments on the sides. There's lots of different structures that could be masking as calf pain. So it'd be good to come and see your doctor for this one, I think. And then the last question is, are turf shoes better to wear on turf to prevent injuries? So I talked about earlier how turf overall for lots of different sports and for lots of different lower extremity body sites, turf does not stand up to natural grass for preventing injuries. Oh, sorry, I got distracted by another question. In terms of turf shoes versus cleats, I don't think we've studied that. I'll have to look back and see if I'm speaking out of turn on this, if any papers came out recently on turf shoes, like indoor tight style shoes versus cleats on the AstroTurf to help mitigate that increased risk. But I'm not sure. I think that the differences in terms of like cleats versus flats, and then in football they have like molded cleats and spikes. Those are helping out more with performance changes, whether you want more grip or more speed. But in terms of injury, how thick your cleats are, I don't know if there's evidence about that. Are you aware of anything like that, Ted?
No, I don't think so. I don't think I've seen anything. Yeah.
Yeah. I think that was our last question. Someone asked if the because in my first slide, I included a preview about some data I'm going to publish next year, 2025, about where kids get injured the most. And someone peeked and saw, oh, wrist is pretty high too, compared to ankles and feet. I think I'd be as excited as you are to do more webinars to talk about other types of injuries. Thankfully for soccer players, they don't get injured of the upper extremity too frequently, but there's many other sports that kids play besides soccer. So look out for more webinars. I'll be happy to continue teaching everybody about what I'm seeing in my clinic and how to stay out of my clinic. I think that's all the questions. Anything else that you want to add, Ted? Otherwise, I think we'll wrap up.
No, I don't think so. There's another question that I don't know if you see. This is the question. Goes about the ankle.
Oh
The
yeah,
ankle pain my kiddo has.
Amy answered that one. She's
Oh, she did.
typing
Okay,
it.
sorry. Yeah, okay, I
Yeah,
didn't
no
see.
problem. But we cleaned it out. But again, thank you everyone for joining us. This was really fun. Like I said, sort of coming full circle and remembering my roots. I was a Cal South player growing up, a lifelong soccer athlete. I specialized in soccer, and so now I'm teaching soccer players not to specialize. Sometimes that feels disingenuous, but it's cool to chat with parents and coaches and help get the medical information out so that we can use it to perform better. But yeah, thanks for joining everyone.